They say there are 5 COVID-19 variants circulating in the Philippines, but the detection of new variants is being delayed by the lack of genome sequencing kits. Will this problem affect the containment of COVID-19? We discuss in this episode of The Chiefs. Welcome to this special edition of The Chiefs. Ako po si Robbie Alampay, and with me online are Ami Pamintuan of the Philippine Star and Lucy Cruz Valdez of News 5. Chiefs, happy Friday!
Happy Friday.
Hello. Happy weekend.
Happy weekend. Ami, ano bang binabantayan nating balita?
May proposal si Joey Concepcion, Presidential Advisor, na investigate daw yung vaccinated people na vaccinated in some establishment, some public establishment. So sabi niya, kinaralan ng gobyerno. Ewan ko anong tingin niya doon. That's a good idea.
Oo nga, in the meantime, we're also
Ano ako?
Oo nga eh. Kaya siguro, pag gano'n na yan, pag malaki na yung coverage ng vaccine.
Yes. The vaccine card.
This
Will
time.
count privileges. Nararamdaman.
In the meantime, binabantayan din natin yung balita sa Indonesia. No? It sort of reminds us of what happened in Brazil. Pero tinitingnan nila dito yung mga medical frontliners, kahit nabakunahan na, nag-positive pa rin. But ayun nga, health experts are also saying, kanina I was listening to Dr. Virhere, sabi niya, if you take that against the total sample, never mind the fact that these were all medical frontliners, it still only accounts for about 3% of the sample. Sabi niya, that's still 97%, that's still near what they were projecting.
Plus, wala naman daw nag-severe. Diba? So, in a way, which is exactly what the vaccine manufacturers and the doctors have been saying, diba? That it really just protects against severity and death. So, I guess that's the point.
Pero nakakatakot siyang mga kumakalat, pati ang Moscow ngayon, tumataas ang mga cases eh. Siguro, talagang yung variant ang problema ngayon, ano?
Oo, exactly.
And the UK.
At the very least, what this does is, apart from just talking about vaccination, it gives us reason to revisit all these discussions about variants, really on the science side of it. That's why our first guest for tonight is Philippine Genome Center Executive Director, Dr. Cynthia Saloma. Good evening, Dr. Saloma.
Good evening.
Hello, Robbie. Hello, Amy. And hello, Lucy. It's nice to be here.
Welcome.
Ma'am, ito, quick lang, no? Because bigyan yung mga tao, ano naman tong Delta na to? Walang bago yan, no? This is still, just to remind everyone, itong Alpha, Beta, Gamma, Delta, this is just para po hindi natin ina-associate yung mga virus kung saan nanggaling. No? But at the same time, hindi natin maiiwasan yun. Just to clarify for everyone, pinag-uusapan ng mga tao ngayon yung Delta variant. This is the one that originated from India, hindi po ba?
Correct. Because it was really designed so that there will be no stigmatization from the places where they were originally are. Kasi kung pala sequence ka, tapos syempre may makikita ka, tapos mas-stigmatize ka pa, di ba? Palang wala kang encouragement na mag-publish o mag-share ng work mo. Kaya they devised this Greek system of nomenclature.
Okay. Pero ma'am, I mean, just a quick backgrounder. Kasi we keep saying, ito, 4 na variant, 5 variant. Ilang variant na po ba? Kaya po bang bilangin kung ilang variant ng ang COVID sa ngayon?
Actually, Robbie, as far as I know, thousands na eh. No? Kasi nanganganak sila ng nanganganak. In the beginning, while I was tracking we were tracking here in the Philippines yung mga variants na ito, I counted something like 132 different kinds of variants. So plus India, siguro mga 135 different kinds of variants have been detected by the Philippine Genome Center since the beginning of the year. Tapos lately, we are seeing na yung mga dating variants na nakikita natin noong January are being superseded by the variants of concern.
So, dami na pala, no?
But of course, ngayon, iba na.
Not all of them are, well, let's just say threatening, no?
Correct.
So how many would you consider really threatening aside from the ones that we already know are here, no? Aside from the Indian variant, it looks to us like it's the worst right now, no?
Correct.
It's the most threatening. But the South African variant is still there, right?
Yeah, and we have a lot.
And yung UK,
We also have a
ayun
lot.
yun, no? Tapos may Brazil pa, di ba?
Oh, pero yung Brazil,
And-
which is the
yeah.
gamma, no, the gamma variant, we don't really think so much about it kasi we only have two. Oo, dalawa lang.
Okay.
So, parang hindi siya factor. Pero yung beta at saka yung alpha, they are still concerning. And when we were sequencing some samples from Mindanao, on northern Luzon, we were detecting some of the variants that have been collected from cases na mayroong spikes of cases.
Okay, ang pinaka nakakatakot yung Delta no? Yung Indian.
In the beginning,
Yes. Sabi po ni Dr. Vergere, wala pa raw community transmission nun. But at the rate the genome sequencing is going, how do we know, ma'am, that it won't be too late before we find out na meron ng community transmission?
So, yeah, because the emergence of the Indian variant, bago lang naman din ito, ano? So, so for as long as we keep our borders, the border control strong, I think we will be able to delay the emergence or the appearance of this in the community. So we are lucky that we were able to detect 13 so far, all from ROFs and all under quarantine. So far, wala pa tayo sa community. So, of course, many people have been concerned kasi we have not been sequencing a lot of samples lately, correct? But I'm happy to note and to announce to everyone that starting next week, we will be doing 750 every week. Kasi finally, darating na yung ating in-order na mga samples, mga kits for sequencing. So, we have kits good for 1 year na. Finally.
Doctor, tanungin ko nga yan yung
Kits na yan.
Philippine Genome Center. Kung pagkaintindi ko, yan na yung original capability nyo, di ba? 750
Yeah, actually,
per
yeah.
week.
Yeah,
So,
so,
hindi pala siya nag-i-increase. In fact, bumagal siya in the past weeks.
oo, in the past weeks
Nagkaroon ng
kasi,
ganung problema.
yung genome sequencing per se, hindi naman ito yung RT-PCR na method, di ba? It requires a lot of expertise. The method is very tedious kasi i-sequence mo yung buong 30,000 ng 750 samples. So, on the one hand, parang gusto mong mag-sequence as many as possible, pero value for money, when you really think about it, probably around 750 a week is reasonable. And it's not only us, but other sequencing centers around the world, 750 a week din ang ginagawa nila. So it's always in the multiples of 750. Kasi sa 750, that gives you that turnaround time that you can get at the same time yung kits na ginagamit mo. If you lower than 750, cost per sequencing is also going to be very expensive.
But how is that enough if we're getting about 6,000 to 7,000 cases?
So even, correct.
Ano ginagawa ninyo kapag ganon?
So it's really, really statistical sampling. So actually, the OH Epidemiology Bureau, together with the Technical Advisory Group and the Technical Working Group on COVID variants, we're trying to refine our protocols to get a much better picture of the samples in the Philippines. Kasi hindi naman talaga kayang i-sequence lahat. So for example, the most advanced sequencing facility in the world na network is the one of the Public Health England. And this is a network of 17 labs that are funded at about $36 million in the beginning of the year. Tapos yung US, even in the US, for example, in the beginning, hindi naman din marami sinisequence nila. And by the way, ang Philippines pala in the ASEAN has the highest number of shared sequences in the global initiative for sharing all influenza data. So we would like to share with our audience na yung Pilipinas ang may pinakamaraming na i-deposit na sequences dito sa GSAID database. So we are number 1 in terms of deposit among ASEAN nations. Second, we are followed by Singapore with about 3,000, and then Indonesia. So hindi po trivial yung ating ginagawa kasi yung Pilipinas, we have deposited as of yesterday 4,305 sequences, and we are adding more. Singapore has deposited 3,080 sequences. Indonesia, with their cases, has deposited about 1,978 whole genome sequences. Thailand, 1,700. Malaysia, 1,184. So even if you say that we're sequencing only 750 a week, actually we are sequencing a lot, compared to the other.
But ma'am, syempre, on the ground po, what this means is hopefully if we get more data and we get it
Yeah,
faster, we all get
correct.
to respond. Our leaders, our policymakers get to respond faster also. But just curious lang po, when you say that we have enough, the 750 per day.
Nothing is ever enough.
Tama, yes. But when we're at that level, as you said, gaya nga po, sabi nyo, the turnaround time is faster. What does that mean? The turnaround time
So
is
for
what?
example,
Yeah.
Okay, so the kits that we're using, it's called the Illumina COVID-sick kit, which is version 2. So yung dati, yung whole genome sequencing, hindi naman ito maramihan, isa-isa. Actually, when we sequence bacteria, we sequence ganito, isa-isa talaga yung genome, gano'n, no? So the virus, they were able to design a way by which we can sequence simultaneously. How do we do that? Ibig sabihin, naka-barcode bawat isa, tapos pinagdugtong-dugtong sila in one tube, tapos eventually, bioinformatically, sa computer, malalaman mo kung anong barcode ng bawat isa, at pwede mo siya ma-assemble. So, hindi trivial ang gumawa ng whole genome sequencing. The technology and the people who have to work this have to be trained very, very well. And number 2 is you need to have in your system bioinformatics. Hindi mo pwedeng i-sequence lang na wala kang computer expertise. So actually, in the Philippine Genome Center, as I've mentioned several times, we have prepared for the pandemic 5-6 years ago when we started investments in the sequencing machine. So the one that we're using for the 750 is actually the most powerful Illumina machine that we know of. So actually that machine can sequence 3,000 in one go, but we did not choose 3,000 because just to process 3,000 will take many more days. Kaya we chose 750 and we realized many other labs around the world are also using 750 turnaround. Each lab 750. It's just that in the Philippines, kami lang ang nag-750. Primarily because kami rin din ang may machine na yan.
Pasensya na po, I think I missed the detail there. But what does that mean in terms of being able to give our policymakers and our health experts the findings? How fast does it take? How much time does it save? Does it allow us para we're not too far behind on the cases? And as Luchi said, we can more or less try to keep pace with these variants.
So sa genomic biosurveillance, actually there are 2 kinds. One, yung gusto mo talaga malaman yung active cases, right? If you want to get the active cases, then the turnaround time has to be fast. Okay. Meron namang iba na yung purpose is not just to do active cases, but to see the breadth of the spread of the virus. So iba yun. Hindi siya time-bound, no? So but eventually you are actually sequencing biobank samples. So the Philippines has to create a balance as how many percent of the 750 a week we sequence should be devoted to active cases or to those where we have increased breadth. Kasi for example, we have to get samples from Mindanao. So my travel time, my check-up, and then your extraction, the sequencing itself. So it will probably take about a week talaga, no? From the receipt up to a week. So you have to inspect everything. But kung minsan, you remember, we have these cases sa NCR, we have to sequence overnight. Kaya din namin yun, no? We can sequence overnight, but
So kaya
ang overnight. Pero kung overnight, usually ang mga samples na sinisequence namin 50, because we can do it in 30 hours.
And ano yung 50?
Ibang machine.
Okay.
Tapos,
it's not enough to draw a conclusion. I mean, how much of a conclusion?
So for example,
Yeah,
I'll just give you an
how
example.
conclusive is 50?
So it's really statistical kasi.
Yeah.
So for example, kami naman sa Philippine Genome Center, we just received samples and it's really designed by our epidemiology.
Nag-freeze.
Nag-freeze yata.
Ma'am, naghang po kayo.
In Baguio.
Ayan.
Ay, ako ang naghang. Okay.
Opo,
Ayan. Sige pa.
can you just say that again? So, for example, you
So
were
for
saying...
example,
Yeah. Yes, ma'am.
Talagang
and then there is a spike of cases in a city, in NCR. So what we did was we sequenced overnight, 50. Yung Pasay, we sequenced it overnight and we immediately knew that it it was the African or the Beta variant. So we sequenced it overnight. So in those cases, I think it will be a combination of yung 750 and then a portion that will be done overnight, particularly when you need to respond and know the answer very fast. So,
So
but the
where are
process
you?
itself,
Yes.
so yung depende kung, let's say, if we need to do sequencing fast, that's 750, we use a lower end machine. A lower end machine.
So
Oo.
may ganun.
So the Philippine Genome Center has about 5 high-end machines. So it depends on the target and the kit. So pag kailangan talagang mabilisan, 750. Pero you know, yung mga tao nag-genome sequencing, hindi talaga nagsisequence ng maramihan yan. Usually, isa-isa lang yan. And it's really, really a testimony to the help of the global community that they devised primers which can amplify or target, you know, the virus. Can you imagine, when a swab is done, ilan lang ang porsyento ng virus na yan at yung genetic material ng virus kailangan mo hanapin. So the way to do that is to really do enrichment, tinatawag natin enrichment. Pinaparami natin yung sequence ng virus para, and that is 30,000 bases. Oo, di ba? Papadamihin. Repeated PCRs yun. Ibig sabihin, repeated polymerase chain reaction overlapping, and they will be assembled by the computer later on. So normally sa genome sequencing, isa-isa lang talaga ginagawa mo. The fact that we can do 750 is already a big deal. So all other machines that
So, Doctor,
yeah.
Doctor, you can reassure us kasi pag tinignan mo talaga yung 750 a week compared to 6,000 a day, parang
Pero true. Ay, oo nga. Hindi ko pala na-complete yung story ko. So, for example, Public Health England, yung budget nila, 37 million yata, no, in the beginning of the year. And it's a network of 17 big academic institutions and research institutions in the entire England, run by consortium na ito is Public Health England. Ang kanilang sinisequence is about 9% of their entire cases. Okay? 9%. Oh, yung US, less than 1% of their entire cases. Yung Philippines, so far, yung sinisequence natin is about 0.8% of our cases. Singapore is sequencing about 3%. Japan is sequencing about 4-5%. So wala naman talaga nagsisequence ng 100% except yung country siguro na yung cases nila hindi masyadong marami o marami sila.
Pero Doctor, you can reassure us na representative yun ng situation in the Philippines.
So
sequence nyo.
actually it's really upon it's really upon the advice of the DOH, no? So for example, last week mayroon tayong requests from Zamboanga at saka yung kits natin na marami hindi pa dumating. But we had kits of about 70, 100 through the help of the DOST. So we utilizes and we sequenced some samples from Zamboanga, from the Oro, and immediately nakita natin, wow, parang 54 African variant. Grabe. That was in many ways.
So I guess, Doktora, I think maybe another way of asking it is, halimbawa binalita ngayon na, merong 12 variants ng Delta. No? What are we talking about? Are we talking about a snapshot of 2 weeks ago, or are we talking about a snapshot of something as recent as 3 or 2 days ago?
Okay, so it depends on the samples we receive, right? So the samples we receive are determined by the Epidemiology Bureau, so and also by the cooperation of the LGUs and the labs. So sa NCR, hindi masyadong mahirap logistics dito kasi let's say, may sample sa Pasay o may sample sa airport, didiretso lang natin sa Diliman, di padali na. You can get a snapshot of the last 2 days or 3 days. But the one that is, pero yung mga 750, some samples are 2 weeks old, some samples are 1 week old, some samples from time to time is 3 months ago. Kasi meron silang mga biobank samples na pinadala na kung minsan may cap. So, but most of the time, so it really depends on the, ano ba talaga purpose natin? Gusto ba talaga natin real time? Or gusto ba natin yung snapshot ng spread sa country natin? So I think it should be a combination of both.
Okay.
But for example, if we're monitoring the Delta variant, what kind of what kind of action are you taking to make sure that we're able to catch it as quickly as possible at the earliest possible
So
time?
yung Delta variant, whatever samples that are sent to us, we sequence, correct? But if you really think about yung control of the Delta variant and not going to the communities, it's really border control. you know. If you just stick to strict border control and then compliance with the quarantine, we are protected because the moment we identify it's a Delta variant, the management is still the same, right? It's still the same. But what is important is they have been contained in the facility and they were not able to infect others. Yeah.
But is the Philippine Genome Center involved in any study on the efficacy of the vaccines we have now in the Philippines against these variants? Kasi nagkakaproblema ngayon in other countries, we're seeing kahit mataas na yung vaccination rate, nagkakaroon sila ng mga flare-ups. And they're blaming the variants. Are you involved in any way in any study on
So,
that?
so you just this afternoon, we're actually looking for funding support.
Yes.
There is a way by which we can see, for example, yung effect ng mga antibodies from the vaccinated or those that have been infected against the different variants, no, on whether, let's say, vaccinated siya with A, B, C type of vaccine, and then the virus, the antibodies generated by this individual for time, pwede siyang titingnan kung effective ba siya sa neutralization ng virus na yan. Yun po yung dinipend namin proposal this afternoon to the PCHRD, and we have urging our government that we be funded now kasi the answer should be done now. So, so we
How much
depended
are you asking? How much are you asking? Siguro,
so for the pseudovirus, we were asking something like 7 million.
7
For the
million.
pseudovirus.
Kaya. Nax, kaya.
Kaya yun ang
Oo nga.
Actually, 3.5 million nga lang sa first year. Eh.
Oo, kasi mga 20 billion for the vaccine.
Madam Ami, itong ginagawa natin. So for example, kasi mga genetic engineers ang molecular biologists sa MBB, di ba? So if ever there is a new kind of variant or mutation, pwede kang kasi gumawa ng pseudovirus, no? Hindi siya replication incompetent. Yung pseudovirus, doon mo siya i-attach yung spike protein na yan at pwede mo siyang tingnan in vitro kung a-attach ba siya dito sa viral cells o sa ating cell lines kung baga pina-express mo ng receptor ng virus. Tapos matitingnan mo ngayon in real time, for example, of course, you can do fluorometric assay, kung mataas ba yung kanyang neutralization assay o hindi. So it's actually very, very versatile. That is one, ginagamit natin, tawag natin ng pseudovirus. The other one is, of course, talagang ang virus i-isolate mo at doon mo siya i-test. No? That can also be done, but that can only be done in a P3 laboratory or a biosafety level 3 laboratory where we have at NIH in UP Manila. So kasama po namin sa project yan. Sana mabigyan kami ng pera at
na-approve ba yun?
Pero ma'am, I guess ang tanong is, will the results of that study affect the purchasing decisions we're going to make moving forward in terms of what brands of vaccine?
Actually, very important question.
Yeah, we're going to be acquiring.
Correct. So that's very important. Particularly, we also have the Theta variant, diba? Mga P.2, the Philippine variant. So this is also part of our study. So our study can actually give an answer to those questions. Kasi maganda sa Pilipinas, maraming vaccines tayo. So maraming klase tayong vaccines na vaccinated individuals ang papag-aralan natin. Kasi yung ibang countries, Pfizer lang sila, Astra lang sila, dalawa lang vaccines sila. Sa Pilipinas, we have about 8. And we are in a unique opportunity na pwede natin silang matest. Diba?
Yes.
So yun din ang aming pagkumbinsi sa DOST na sana bigyan kami ng pondo because this is a question we want answered. And the clinicians also want an answer. So now, whatever the results will be, then it will depend on our vaccine procurement. Kasi hindi naman, that can inform decisions actually.
Okay, so dapat hindi mo na ako magpabakuna. Antayin ko muna.
Hindi naman. Nakita niyo yung, Luchi, nakita niyo yung Delta variant, kailangan makalawa ka, bakuna. Makalawa.
Actually, Dr. Saloma, I was gonna ask nga, because we know we're running out of time for this segment. One last question. Ay, sana makuha niyo yung 7 million. Kung meron po diyang may 7 million, kailangan nila ng 7 million. And we know that you need that extra capacity because this is a moving target. This is going to be continuing work. Walang tigil tong paghabol sa virus tsaka sa mga variants. But right now, that na pinag-uusapan na naman ng variants, what do we know right now about the efficacy of the batch of vaccines that we have relative to the variants, regardless of the variant?
I think all EUA, no, yung lahat ng mga vaccines na ginagamit natin sa Pilipinas at in-approve for emergency use authorization, emergency use authorization ng FDA, are all effective against severe to critical.
Ayan na, Luchi,
severe to critical. So yun ang pinaka-importante at saka hospitalization. And if you see the data from England and Scotland, it shows that Pfizer as well as AstraZeneca are effective against the Delta variant pag makalawa ka na may makalawa 2 doses na pagkamo mga 2 weeks later. Ibang-iba, 90%, no? Yung kanyang protection from hospitalization. Pero kung isa lang, 30%. Yeah, importante na, we delay the entry of this variant sa country natin para ma-ramp up pa natin ang ating vaccinations, particularly for the vulnerable.
Doctor, isa na lang. Do you have enough people in the Genome Center to do all the testing? Do you need more people?
We have a lot of people, so we're getting the best talents of UP Diliman and the entire country. So we have a team. We have about 11 bioinformaticians. Many of these are graduates of computer science in UP Diliman, and others are molecular biologists. And then we also have a team of molecular biologists for the sequencing, and of course our medical technologists. We have 2 doctors. So the DOH has been generous in helping us acquire manpower support. And finally, of course, we got permanent items from the BBM so that we can have, give items to many people we have trained, particularly for sequencing. So okay naman, probably we're a team of about 100 in the Genome Center.
Yung 7 million na lang talaga kailangan. Sana ma-aprobahan bukas.
Push natin yan. Push mo yan, Ani.
So this is a project between the Philippine Genome Center, NBD in UP Diliman, and the National Institutes of Health in UP.
National
Institutes of Health.
Okay.
Okay. Okay,
All right.
Dr. Saloma, Dr. Cynthia Saloma, Executive Director of the Philippine Genome Center, maraming salamat po.
Maraming
Thank
salamat
you, Doc.
po. Stay safe, everyone.
Maraming salamat po.
Thank you.
Made an appearance si Doc dito, ha?
Please stay with us. The Chiefs will be right back. Welcome back to the Chiefs here on One News. I'm Robbie Alampay. With me are Ami Pamituan and Lucy Cruz Valdez. And now joining us is Dr. Ted Herbosa, Special Advisor to the National Task Force on COVID-19. Good evening, Dr. Herbosa.
Good evening. Welcome back, Doc.
We always invite you, hoping you clarify a lot of things for us, given your access to the IATF. Let's start with the number one thing that's confusing a lot of people, itong face shields. Ano po ba? Kailangan po bang mag-face shield? Meron na ba talagang policy on this?
Okay, take a deep breath. There's so many information and levels of statements made by the President, the Senate President, the Secretary of Health, 2 undersecretaries of the Department of Health. I hope I can clarify this. Science-based policies are always solid. When they say you wear a face shield and it lowers transmission because of the additional barrier, that is true. That is true. But when you apply it as a policy, there is a certain difference because ako, nadapa na ako wearing a face shield, with the mist there and then I missed my step. So there are consequences of the science that protects you from transmission. So this is where the debate really is. The debate really is, are there people there who don't want to wear the face shield? And for several reasons that may be valid. So I like at the most of all the statements made, I like the most of Yusek Bong Vega, and which I think is the one that the IATF eventually prevailed on. And they said that in open spaces, you don't need to wear the face shield. And when you can keep distance from the people around you, you may remove the face shield. But in places where social distancing cannot be possible, like inside an airplane, inside a confined space, inside the hospital, inside the LRT, MRT, jeepney, then it is only logical that you wear additional protection using the face shield. And I will do the same. I will do the same and wear the face shield as an additional protection. So
Hey,
I think that's the best
Dr.
explanation
Herbosa,
I will make.
pasensya na po susundutin ko pa rin. Because among the things that you said, you think, among the things that have been said, I like. And you said, I think, this is what we prevailed upon. This is something to encourage. And so, but the question for everyone is this policy?
So as of now, I'm actually, the policy that's been stated, I think as of noon today, from I think from the Malacanang is that the IATF technical advisor is going to request the president na to allow the use of the face shield in confined spaces. Yun ang nadinig ko. And make it optional in open spaces, in spaces outdoors. So yun yung alam ko, instead of just in the hospital. Because I think the statement quoted from the president, and I don't know if that's policy because that was a conversation between the Senate president and the Philippine president. I don't know if that's policy already. So I guess they will defer to whatever the technical advisory group of IATF. So there's no confusion. In other words, I'll shorten it and make it, there is no confusion that the face shield affords protection, additional protection. Where should we wear it? That's where the debate and the policy becomes blurry. So yun lang yung ano. And I, from my scientific perspective, say you use the face shield when you cannot socially distance, when you are close to people, when you are in a confined space, where the chances of getting infected is higher. I hope that's clear.
Ang confusion nga yung policy. Ang sabi ng DOH until the President approves the IATF recommendation, the status quo stays, which is yung regulation on the use of face shields.
Okay, so that's the other thing that confused me. So listening to all the reports, and Ami is right, they said status quo. But there were two status quo. Apparently from...
Daw nagsalita si Presidente na status quo. Yan ang sinabi nila. Until they approve daw.
So I don't know who said it, but said it's status quo until the appeal of the IATF and the technical expert to the president happened. We wear the face shield. So that's the other status quo. The other status quo is, no, the status quo is the president has said wear only in the hospital and no need to wear it, it's optional. That's the status quo. So I'm as confused as you are. I'll have to read in writing what the policy is because this is all out of news. So maybe I'll just wait for the written one and be able to read for myself what the written policy is. That's eventually, if I'm confused from what people say, I'll wait for the document and the final document with the signed by the official policymaker.
Iba problematic yan. It indicates a problem in the pandemic response kung ganyang kagulo. In a basic protocol like that, hindi tayo magkaintindihan. Doesn't that indicate a deep problem in the response?
No, it's the same with anything, whether it's law or medicine. You go to a doctor and you go to a second doctor for a second opinion. It's basically the same with a lawyer. You go to a lawyer, you have 10 lawyers, you have 20 interpretations of the law. So I see no problem with it. It's always what it needs is clarity so that the people in the policymakers and the scientists will converge and say the same thing. So I think it all needs just a meeting and a discussion. It will be ironed out.
In fact, tinatanong ni Senate President Soto kanina, who's in charge ba talaga? Tingnan daw bang pati siya nandito na. O, kanina lang yan. Di
Well,
ba?
with all due respect to the Senate President, he started the confusion by asking us to not wear the face shield. Because of his protest and his request to remove it, we ended up doubting what we were actually doing. Because he questioned the fact that we're the only country with this policy. And
Yeah,
yet, I think, honestly, without the face shield, we wouldn't have flattened the curve last year after the July-August peak, all the way till Christmas and after Christmas. So I think, if you ask me, the experience, the empirical evidence is there. We lowered it, and then when people said, oh, there are variants, we need to wear double masks, said the CDC of the United States. Well, we technically were doing double masks since July of last year because we implemented the face shield and the face mask, because that's a double mask technique as well. So now when I go out, what do? I wear a double mask. I wear a surgical mask. On top of it is a KN95 mask. And then I wear the face shield. And I follow that streak. And I'm fully vaccinated. So no one can stop me from being very careful, because although we've not identified the Delta variant in the Philippines, the Delta variant is all over. It's from the US, it's in the US, it's in the UK, and we may be blocking travelers from India and Oman, but anyone from the US can bring it here. Anyone from the UK can bring it back home. So those are the other threats. So there are loopholes in the quarantine border control.
Okay, talking about vaccination, what do you have to say about the Reuters report in an Indonesian hospital where 5,000 medical workers were already fully vaccinated? 5,000, no? But 350 still actually got infected with COVID. Actually, and many more who are asymptomatic, no? But also infected. Pero yung 350, I think, tama ba ako, Ami? They were,
Yeah, they're
Yeah.
doctors.
oo,
Oh,
doctors mismo.
Actually, number one, I'm not surprised with that data, because the prior data when we were analyzing Sinovac as a vaccine for it, that it had only about 50 to 70% efficacy for mild illness, but it had 100% efficacy for severe and death in terms of preventing it. So that means it doesn't prevent you from getting infected with the mild symptoms. So you get a cough, cold, and if you're a health worker in a hospital with a high viral load of coronavirus 2, your chance of getting infected is there. So that's why even today we're all immunized with whether Sinovac, AstraZeneca, or Pfizer. We still wear our PPEs, our face masks, and our face shield when we handle patients. So the risk of transmission is still there, but
Well,
it's
actually,
protecting you. Now let me continue, because
Yeah.
I read another article after I read the Reuters, and they're identifying the Delta variant in Indonesia.
Yeah.
Okay,
So that situation might be a Delta variant, and we all know that when you have the Delta variant, the efficacy of the vaccine is lower. In fact,
Okay,
the poorest performance is the Pfizer
oo.
among
Well,
the.
yun nga, actually, Doc, yung worry ng marami ngayon is baka mamaya namimili na naman tayo ng mga brand, no? Kasi Sinovac itong experience ng Indonesia na meron ng mga infect. But my question is, are you hearing reports that are similar to this case in Indonesia, but under a different vaccine? Halimbawa, is this happening to, say, Pfizer, Moderna, AstraZeneca, or is it just, for now, Sinovac? Kasi baka mamaya, considering that we have more Sinovac vaccines coming and probably going to be administered, baka magkaroon na naman ng, alam niyo na, vaccine hesitancy kasi Sinovac lang. Baka may ganun.
I'm afraid to say this, but I might get misinterpreted. But I've read the data, and I looked at the data on what vaccines work best against the Delta variant. Guess which one is the best, according to the report. So I don't know in the real world that's really what it is, but these are the claims of the manufacturers. The one with the 70% efficacy on the Delta variant is, guess what? Sputnik V. Got a 70% efficacy. So if I'm not vaccinated today, I'd probably get a Gamaleya Sputnik V because that's my fear is the one. But I've gotten Sinovac, so I have to live with Sinovac. Now, Sinovac is also about 60%. The poorest one is like Pfizer is only 30%. The Delta variant.
Mataas sa UK.
So yung mga tao dyan na nagpapakamatay makakuha ng Pfizer, you might be getting the wrong vaccine if the Delta variant comes in here.
So it doesn't
again,
pay
these
to
are
be
preliminary
choosy pa rin,
data.
ano? Yeah.
You have to match this with real world data and how it happens. You know, when they said Sinovac is only 50%, but in real world data, it was protecting communities in Brazil.
Yeah.
And it had a 90 to 100% efficacy.
Exactly. I think we do have to mention it. Kanina sa big story, we did interview Yusek Vergere of DOH, and she was pointing out, look, 350 sounds frightening, diba? But two contexts there. One is these are medical frontliners, and two, that was a sample of 5,000. So 350 over 5, that's 7%. Which still puts you at that still puts you at a 93% efficacy. And so yun yung inaano ni Yusek Vergere. Let's not forget, 93% we're still protected. Anyway,
that's a good point.
I think it's just an important thing to stress, especially sa mga tao, magpabakuna pa rin po kayo. There's nothing beats being protected. But Dr. Herbosa, if you don't mind, I want to ask you about something else. Like I said, we want to clarify a lot of things with you. Let's talk
Can
about...
I just add something about this statistics with the... So it's a Reuters report. So it's a news report. It's not a scientific report. So if you ask me as a doctor, I'm going to wait for the scientific report on this Indonesia issue so that I can see the true numbers. Then I can tell you and give you my opinion because, you know, it's different when it's written by a journalist as written by a science journalist or a science researcher looking at the data in a balanced way. So that's my statement there. I'll hold my peace until I see the actual numbers and the actual assessment by a peer-reviewed published journal.
In a way, this is similar to that news report that came out sa Brazil, di ba? Where people were reacting to yung efficacy sa Brazil. Then it turned out this was also specific to medical frontliners. But anyway, I want to clarify one more thing kasi nasa balita rin kayo kanina sa big story. Let's go to Cebu. This whole debate about the quarantining and how many days should you keep them, which led to international flights into Mactan being diverted into NAIA. Tama po ba? May resolution na po ba dito? May compromise na?
Yeah, I think the IATF already said that they don't want to change the national policy, and the national policy is facility quarantine. So it's not the swabbing, it's the facility quarantine because what Cebu did that was different from the national policy was if you swab negative on arrival, they allowed you home quarantine. That's what the national government doesn't want. You can swab on arrival if you want, but you have to be in a quarantine facility. That means a quarantine hotel or a quarantine facility for 10 days. And then you can do the home quarantine for 4 days if you test negative on the 7th day. So very clear. That's a very clear policy that's evolved because we used to do the swab on arrival. And what happened? We implanted and inoculated several OFWs and returning Filipinos who tested negative on the day of arrival. But when they reached the LGUs, they were testing positive and the LGUs were getting mad at the National Task Force for allowing them to get to their place. So
it's
the policy changed. It went 5 days. Now it's 7 days.
7 days.
Now Cebu did what we call a 2-test intervention. It's actually good because you spend more because you can test on arrival and that's the first reading. You say it's negative, and if there's positive, nahuli mo na siya, di ba? So that's good. And then you test again at the 7th day. So it's actually a better policy. But what we don't want, what the experts didn't want was sending for them for home quarantine if they were negative, because the policy was facility quarantine, and the reason is the Delta variant. We don't want the Delta variant to enter this country.
Doctor, how important is it to have a uniform policy on these things?
So this is border control.
Kasi they're invoking yung independent
Autonomy.
autonomy of the local government. But on the other hand, the national government is saying dapat sumunod kayo sa IATF. Kayo, anong tingin niyo?
Well, actually, the issue there is what people mistake is the testing. It's actually the home quarantine that's the issue,
Yes.
because they've relaxed a national policy that was strict.
But that's what they're saying, that they know that the situation, their capacity better, that Cebu does not have all the hotel facilities for the facility quarantine. Kaya nako-contain naman daw nila. That's what they're saying. I mean, can local governments argue in this way na i-exempt nyo na kami kasi kami may capability naman?
Well, they were listened to.
Policy.
I mean, that's correct. They sought an audience with the president. They went directly to the president. In fact, we discussed this in our planning, that we hope that there would be a technical working group or a completed staff work of requests by LGUs, and then looking at the science of what they're requesting before they even go up all the way to the president. So we're looking at National Action Planning Phase 4, and this were one of the issues we discussed. And we said, maybe this requires completed staff work before it even goes up to the president. Because what the president did was just throw it back to the technical people and tell me what you think of it. And the technical people said, no, they should still follow the national policy. And,
Okay, just for purposes of argumentation, no, what is wrong with sending them home? Is it? But you know, the Cebu government is making sure that they know exactly how to trace these people. So they're in effect saying, well, if they're negative, yeah, why don't we send them home and then do a follow-up 7 days after? What is wrong with that?
That's because of what happened to us, because we realized that everyone that comes and rides the airplane prior to arrival were tested from their origin. They get a PCR negative. So allegedly, everyone you rode with on the plane are PCR negative. But someone there might be having symptoms or started to have the virus but tested negative. And then you get infected in the plane after 6 to 8 hours in that airplane, gotten the virus. On arrival, you will test negative because you don't have the incubation period. So if you go home or home quarantine, and after 5 days you have symptoms, you have already interacted with locals. You have interacted with your spouse, with your daughter, with your child, with your son, and you have now introduced it into the community.
Hindi ba go home?
Quarantine. Quarantine means getting people who are suspected, who are not ill, and making sure they do not enter society. That's the word quarantine, from the Greek word quarantos, 40 days. When they landed ships before, they put you on an island, Ellis Island, or in San Francisco, that big island. And after 40 days, that's when they're sure you're not sick. That's the only time they let you in the mainland. So that's the idea of a quarantine. Normal people, you watch them until you prove after a period of time, in our case, 14 days, 10 days in a facility, 4 days in a home quarantine if they test negative on the 7th day.
Okay. Now, Doc, one more thing to clarify. Another source of confusion. Anong policy natin sa mga walk-in, sa mga vaccination centers? Kasi iba-iba yung policy sa mga LGUs. Manila, for one, is the most notorious / most famous for allowing walk-ins. Ano ba talaga ang policy?
The National Vaccine Operations Center has already stated a no walk-in policy, because if you implement a walk-in policy, people will aggregate in the vaccination center hoping to get a vaccination that day, even if you say they're a chance passenger. On the other hand, why are the LGUs doing this, especially when because sometimes you have a vial of, let's say, AstraZeneca, and it has several doses, 10 doses in a vial. Pfizer has like 4 doses in a vial. If, let's say, there is a no-show, sometimes I've heard where in cases someone accompanying the senior citizen, oh, do you like to be vaccinated? There's an extra dose here. Of course, you'll say yes. I'll get vaccinated, especially if you want. So that's why some people say, I just walked in and I got vaccinated. Actually, they were accompanying their someone who was scheduled, and they probably had extra from a no-show. And what we do is they get a quick substitution person. para walang masayang na vaccine. Ginto yan eh. Pinaghirapan ni Secretary Galvez dalhin dito yan. And sayang naman kung ma-waste.
But
Okay.
I asked because last week we were talking to Mayor Marcy Chodoro. I hope I'm not misrepresenting. All mistakes are mine. But I seem to recall him saying, kasi tinanong siya ni Bok, ano ba yung sistema for allocation? Ano ba yung formula for what you get? Is it population? Is it the size of your city? Is it does it take into account transient workers and so on? And I think Mayor Chodoro said, no, actually it's capacity. It's capacity to deliver. But doesn't that in effect incentivize, let's say, a city like Manila to say that, oh, kami, marami, and that's exactly what Mayor Isko Moreno says. Marami kaming na-inoculate sa first round, therefore they're getting more, and therefore doesn't that incentivize a city to essentially, as Mayor Moreno has effectively done, open up to anyone who wants it?
But that's what we call performance-based. In terms of project management of the vaccination, we want to vaccinate as many Filipinos as possible in the fastest possible time. So we're targeting like 500,000 vaccinations per day. By the way, on June 15, we reached 350,000 jabs in a day. About 150 came from the NCR. And this is through the push of Secretary Vince Dizon, who's been pushing the LGUs to deliver. And if you don't deliver the vaccinations, your subsequent deliveries are going to be held because you still have vaccines on stock. So we have what we call a 3-day and a 5-day running stock. So we look at what stocks you have. If your stocks are just in cold storage and they're not being jabbed, you're not going to get your next shots. Show us you are delivering the vaccines and we will give you more. Especially now, that yesterday we had the arrival of 1.5 million doses of Sinovac. Next week, we're getting another 1 million doses of Sinovac. I think Moderna is arriving on the 24th. So vaccines are already flowing in, but we need to make sure that LGUs are delivering at the speed that will make us maskless and shieldless on Christmas.
Okay. Dr. Ted HERBOSA, Special Advisor to the National Task Force on COVID-19. Maraming salamat po.
Maraming salamat.
Thank you, Doc.
And that's all for this special edition of The Chiefs. We hope what was discussed here will keep the conversation going. Before we go, a reminder to our viewers, mask on, wash hands, and stay safe, Philippines. I'm Robbie Alampay.
I'm Ami Paminton of the Philippine Star.
I'm Lucy Cruz Valdez of News 5, and we are One News.